Hey guys, time to finish up chapter 18. We're going to be doing part 3, talking about some of the other formed elements, and we're going to talk about coagulation. Alright, let's jump right on into it. Leukocytes, these are the white cells. We kind of briefly touched on these guys, but let's go into a little bit more detail. These are the formed elements that are complete cells because they have their nuclei and the organelles. So we have the lymphocytes, the monocytes, eosinophils, basophils, and neutrophils. Now we're going to talk a lot more about these when we get to the immune system as far as their specific functions. So right now we're going to try to keep it kind of light on that and just talk about some of their other properties. So the leukocytes, these white cells, these are our immune system, guys. These are the guys that are going to protect us from the bad guys. We're talking about bacteria, viruses, parasites, toxins, and especially tumor cells. We make a lot of cancer cells or precancerous cells every day, and these guys jump on them and kill them before they can develop into a cancer. They work really good. They fail every once in a while, but sometimes that's enough for a person to get cancer. Okay, now these guys are in the blood. We know they start in the bone marrow where they are formed. They get into the blood and they protrude through. Now, the bacteria get into our tissues, generally through cuts or some sort of scrapes or holes in our skin's defenses that allow them to get in. You see all these bacteria down here. Now, these bacteria are going to release chemicals, and the damaged tissues are going to release chemicals to notify these white cells that there's a problem and more than likely potential infection going on. So what's going to happen, these guys, when this happens, we're going to get inflammation. This blood vessel right here is actually, this capillary is going to actually open up. In other words, it's going to get bigger in diameter, and these cell gaps between the cells making up the walls are going to get a little wider. In addition to which, these guys are going to produce these receptors on the inside of the blood vessels, C.L. Lewis, while the white cells, based upon those chemicals, are going to produce something called L-selectins. What's going to happen is these guys are rolling and they grab onto these receptors. They don't hold very tightly, but they go through several of these receptors and they basically roll to a stop. Remember, these vessels in the blood vessels, for the size of these cells, these guys are going at a scale speed of close to 200 miles an hour, which is what the Indianapolis 500 racers go. You don't stop suddenly at 200 miles an hour. So these guys are going to gradually, they're going to stick to these C.L. Lewis, and they're going to gradually come to a stop. When they come to the stop, they get rid of their L-selectins, and there is another receptor on the endothelium called an E-selectin, and there's also another molecule on the outside of these guys called an integrin. They're going to bind to these guys. They're going to adhere, and this is where these guys do the whole thing that all this is for. They're going to do diapedesis. Diapedesis means that these guys are going to squeeze through those gaps in between the blood vessels so that the cells can get out there where the bad guys actually are. Now, they follow the trails of chemokines. Chemokines are these guys are going to release chemokines. Some of the cells in here are going to release chemokines. And we'll talk more about this in the immune system, but basically these are, you don't have to memorize these chemicals right now. Just know that these are, we'll just call them chemokines, chemicals that are released that these white cells follow them back. Obviously, as they get closer to where the action is, there's going to be more and more of these chemokines. So all they're really doing is are following a concentration gradient. When they get there, that's where the bad guys are. This particular one here, if you guys don't recognize it, is a neutrophil. So the neutrophil, and they are like the first responders, are going to come in here and they're going to start engulfing these bacteria so that they can destroy them. That's kind of what the leukocytes, this is what the neutrophils do. Later on, the macrophages will come and they're a lot bigger and they're going to do more harm to the bacteria. But that's, again, that's an immune system thing. Here's our leukocytes. We talked about it. Never let monkeys eat bananas. There's not the right new order. But the neutrophils, seeing this guy, you can see those are normal red cells and they're normal size, normal cytic. You can see that these neutrophils, their relative size, they're going to be a little bit bigger. Remember I told you these guys had lobe nuclei, and you can see that these guys are full of little granules, little circular granules, but these guys are clear neutrophil, multi-lobed, pale red and blue cytoplasmic granules. Well, if you say so, it looks clear to me. Okay. And then here's another guy, an eosinophil. He's got a bilobe nucleus, but the real way to tell this guy is he's got these red granules. And a lot of times, like in the basophil we're going to get to, sometimes you can't even see the nucleus because of all the granules, but in this case we can. How would I know eosinophil? Eosin means red. So eosinophil is the red granulocyte. You can tell that these are little granules. The basophil also has granules, but their granules are kind of somewhere between purple, blue, and black. And a lot of times these got a bilobe nucleus, but this time you absolutely cannot see it. It's covered. Now all these white cells that have granules are called, not surprisingly, granulocytes. So we have these three granulocytes. One doesn't have any color with the neutrophils, one with red and one with purple. We'll just call it purple. And now the other two white cells are agranulocytes. These are real easy to tell. Number one, there's the lymphocyte. Now these guys come in different flavors, but that surely is for different. Notice that that lymphocyte, almost the entire part of that cell is taken up by the nucleus. Also notice that it's much smaller than any of these other cells. So that's how you tell a lymphocyte. There are no granules in its cytoplasm. That's why it's an agranulocyte. And the nucleus takes up the majority of the space. And then finally we have the monocyte. These guys are going to become macrophages. These guys have got horseshoe or kidney shaped nuclei. There are no granules in there, and the biggest thing is these guys are the whopping biggest of the white cells. They are way bigger. If you were to look at these average red cell, you could probably get about 3 or 4 of those inside the macrophage, or excuse me, the monocyte. Whereas here, you could probably get 2, maybe, in there. This one, you can get just about 1. So it's just giving you the relative sizes, guys. I'm not expecting you to memorize that. I want to give you an opportunity to have an easy way to remember these guys, to catch them on the exam. Leukocyte formation, we talked about erythropoiesis. Now we're going to talk about the rest of the cells. There's our hemocytoblast, the hemopoietic stem cell. Now, these guys can only go 2 ways depending on the chemical signals. They can become a lymphoid stem cell or they can become a myeloid stem cell. Now, we don't show this, but the myeloid is what gives rise to the erythrocytes. The proerythroblast is going to come off the myeloid stem cell. They're not showing it here because we're only talking about white cells. Let's go ahead and divide these guys. Oops. See if I can undo that. Okay. So the other thing these guys can become, the hemocytoblasts, they can become a lymphoid stem cell. They become a lymphoid stem cell, then they have exactly two choices. They can become one for the B lymphocyte or for the T lymphocyte. How can you tell these guys apart? Well, you really can under a microscope. They look exactly alike, but they do totally different functions, and we'll talk about that in the immune chapter. In any case, this prolymphoblast for the Bs are going to give rise to B lymphocytes. These will later become something called plasma cells, but we're not interested in that. That is for the immune chapter. These guys will be pro-lymphoblastic T cells. They'll become T lymphocytes. Now, that's kind of easy to deal with those guys. That's it. That's them. That's all they do. So now for the rest of these guys, the myeloid stem cell, we already said they give rise to the erythrocytes. They also give rise to the megakaryocytes, which give rise to the platelets. But again, let's just focus strictly on the white cells. So the myeloid, we've got two categories in here, guys. The monoblast, which is going to become a promonocyte and eventually a monocyte. This is an agranulocyte. Now, the rest of these guys are granulocytes. So the myeloid stem cell gives rise to a myeloblast, promyelocyte, and then the eosinophilic or the basophilic or the neutrophilic myelocyte. And then the next stage, these guys are called band cells. Those are kind of important because on the labs, we especially are interested in band cells. It tells us how acute the infection is and how recent. If we're rushing these guys out into the blood to fight, then we've got a lot. Anyway, we'll talk more about that later. And then, of course, these guys give rise to the three different granulocytes: eosinophils, basophils, and neutrophils. So the two branches, and again, remember the myeloid stem cells also give rise to red cells and platelets. And there's our guys, and of course, one of these is an agranulocyte. The other three are granulocytes, and these guys are agranulocytes, but they've got their own separate pathway. All of these cells are going to grow and mature in the bone marrow, and usually they're not released until they're mature. If these band cells get released, it means that we've got an infection, a serious infection going on, and the immune system is rushing these guys out. Now, the only thing that doesn't mature is going to be these T lymphocytes. These guys are actually going to migrate to the thymus, and the thymus is an organ that's, I think we already did the endocrine. It's that organ is located just superior to the heart. Leukocyte disorders, what can go wrong? Well, lots of stuff. Leukemia. Leukemia is where we get one of these, either these blast cells or something further down here, that are going to grow out of control. They're going to grow even though we may not need those type of cells. See, the thing about these guys, which way do these go? It depends on what your body needs. Depending on what your body needs, we're going to put the chemical that's going to make eosinophils or the one that makes basophils. There's chemical signals, growth factors, colony stimulating factors that are going to cause these guys to go. I mean, these are the exact same cell right here, exactly the same. Which way they go depends on the chemical signal they get. So usually we want to control the production based upon what we need. If you've got a bacterial infection in the tissues, you're probably going to make a lot of neutrophils, maybe some monocytes. You're going to send those guys down. These other guys are for different purposes. But I'm just trying to illustrate that's what's going on. And contrast that with leukemia, where these white cells are going to grow without any reason to. The only reason they're doing this is because their DNA is damaged. Now you've only got so much production capacity, and if you make a bunch of white cells that you don't need, that means you can't make as many red cells or many platelets, and that's part of the problems you see with some of these leukemias. You may not see problems immediately with the actual leukemia itself, but you will see problems with the other cells that aren't being made. You might have a tendency to bleed, anemia, being tired. That's some of the situations you find. Overproduction, abnormal white cells, single clone. In other words, we just got one of these. These guys are unspecialized. They're not developing into one of those mature cells. They grow out of control and they're impairing the bone marrow. Now we have these guys divided into different classifications. These are real easy to learn. Leukemias can be acute, quickly advancing, and these guys are coming from stem cells like the, let me go back again. Oops, go back further. Like these myeloid stem cells or even these myoblasts. Those guys are going to cause acute leukemias. Chronic leukemias are going to be something that's going to be a little bit further down the line from these guys. Acute lymphoblastic, that's going to be the lymphoblast. Grows quickly, is common in children, like 6,000 cases a year. That's also abbreviated ALL. AML, acute myelogenous leukemia. Myeloid stem cells, it's quick growing, that's why it's acute. Common in adults and children, 18,000 cases a year. And fortunately, they've got some good treatment from it. These used to be death sentences, guys. Leukemia means get your will in order. You're not going to be here long. But they've got some good treatment modalities now to treat these guys. And here you can see some of the pictures of these abnormal cells. Look how whopping big these guys are. These are not normal, guys. Those lymphocytes, we know lymphocytes are smaller or just about the same size as a red cell. These guys, the myeloid, these things are really weird. They don't look like anything we've seen on our normal stuff. Okay, so there's the acute. Chronic, remember, it's going to be further down in the chain. We have chronic lymphoblastic leukemia, CLL. These guys are going to grow slowly, adults over 55, and about 15,000 cases a year. CML, chronic myelogenous leukemia. The myeloid cells, common in adults, about 6,000 a year. Infectious mononucleosis, this is caused by a bacteria. It's called the Epstein-Barr, EBV. You get a lot of agranulocytes, and they are atypical. Mononucleosis, a lot of these guys can form giant cells, multinucleated. They merge together abnormally. Very contagious. This is the kissing disease. 15 to 24, saliva, mucus, tear, Epstein-Barr, although there is another virus called cytomegalovirus that can mimic these. Headaches, chills, got the lymph nodes are going to be swollen, right upper quadrant pain involving the liver, tired, no energy, fever, sore throat. Anyway, you get the gist on this. Infectious mononucleosis, and the treatment is to gradually recover and gradually increase. You can spend a couple of months down with this guy. Platelets. Okay, now let's go turn to the platelets. So we get a tear in a blood vessel. This is either from the outside or even an inside. We're going to get leakage of fluid. We're going to get red cells that are going to be leaving the blood vessels, which are totally abnormal. Um, this is a problem. So we've got to have a way of plugging that hole while we fix it. So that's what's going on with the platelets. They're going to be the first line because these guys are floating around in your blood. These are fragments of the megakaryocytes. They have a bunch of chemicals in there to help clotting, serotonin, calcium, some enzymes, and they also have this very important thing, platelet-derived growth factor, PDGF. That should be pretty easy to remember, platelet-derived, that you get those from platelets. Hopefully nobody misses that. So when it ruptures or lining, these guys will form a temporary plug to seal that, and we're going to talk a little bit more about that in just a second. Hormone called thrombopoietin. Remember we had erythropoietin to cause the production of red cells. We have this to cause the production of platelets. The megakaryocytes are going to respond to this and grow. They're going to go through mitosis. In other words, they're going to divide, but they're not going, let me rephrase that, they're going to grow like they were going to divide, but they're actually not. Cytokinesis does not happen. So it's going to go from this stage 1 to stage 2 and 3, and finally to the stage 4. The stage 4 is a large cell. It's got a big multi-lobe nucleus, and it's going to put some of its cytoplasmic extensions into the blood vessels. These are sinusoidal, which are blood vessels that have kind of big gaping holes in them. Going to stick it, and they're going to rupture and release platelets into the blood. That's how we make platelets. Hemostasis, this is a method of plugging a hole. Okay, and the first thing, when we get this damage, the smooth muscle that surrounds the blood vessel is going to have a reflex contraction. What's that going to do? Well, it's going to take that big gaping hole and maybe move it a little bit closer together. It's not going to do away with the hole, but it's going to make it not as wide. Now, once this happens, once the collagen that's inside these layers underneath the epithelial cells, once this is exposed, that's going to cause the platelets to stick to them. Those platelets that stick are going to release some of those chemicals we talked about, making the platelets that float around them sticky, and they're going to all stick together and finally going to form a plug. Now, coagulation, the platelet plug, we're going to make a little net made of that protein that I told you guys about called fibrinogen. Fibrinogen is turned off. Fibrin is turned on. So this guy is going to make a net, and not only is he going to be over those platelets, but he's also going to trap some red cells. He's going to make a nice plug, and that's going to keep us from bleeding out. Vascular spasm, platelet plug, and finally the coagulation cascade. And that's where we're going to actually get that fibrin. Now, after we get this, the clot is going to retract. In other words, all of that in here is going to be pulled tighter in. And again, this is just to bring the edges of the tear as close together as possible so it's easier to repair it. This is only a temporary fix. We still have to fix the wall. Okay. I really don't like this one, guys. This is okay, but I'm going to show you the coagulation cascade on a different slide, which is much better, I think. We have chemicals called clotting factors, procoagulants, and they're going to eventually cause fibrin to be changed from fibrinogen to fibrin and do it. Phase one of this coagulation is going to be prothrombin activator. And in phase two, the prothrombin is actually going to change prothrombin into thrombin. Thrombin is going to change fibrinogen into fibrin. So there's the prothrombin activator right there, prothrombinase. It causes prothrombin to become thrombin. Thrombin causes fibrinogen to become fibrin. And the fibrin is the guy that's going to put the net over this and also retract it. There's a real good picture of it right there, photomicrograph. See the red cells? That net-like structure is made of the fibrin protein. These guys get sticky and they stick to each other and they form this net and they make a beautiful plug. Phase 3, thrombin is going to turn the fibrinogen into fibrin. These guys are then going to make long strands, kind of hair-like, and that's going to glue everything together and kind of keep our clot nice and tight. The fibrin, the liquid plasma inside here is going to become kind of gel-like. And you can probably notice that if you've ever had a cut, that initially when it clots, which is what we're talking about, coagulation, it comes kind of gel-like, and of course later on it becomes a scab, but we don't have to go there. While we have calcium, which we know the platelets carry, thrombin will also turn on something called factor 13. That's going to make the fibrin stabilize it, cause it to cross-link each other, and form a nice tight net around it. Okay, clot retraction, we already talked about these guys. The clot's going to retract, going to pull it closer together. And here, okay, here is our thing. Platelet-derived growth factor. That's going to be the guy that's going to cause this clot retraction. He's going to stimulate these smooth muscles to pull toward each other and to bring these edges even closer together so it's easier to bridge. Also, that PDGF is going to stimulate fibroblasts to start dividing and building the fibers that are going to be the basement. Here, the smooth muscle will also divide, fill in this, and eventually these epithelial cells here will divide and grow. And before you know it, the entire wall is back where it started from. Now, once we've got this clot all fixed, that's fine and dandy, but then we fix the wall. Now we got to get rid of the clot because we can't have clots in our system. It's going to actually impede the flow of blood. Fibrinolysis is how we're going to get rid of this. We've got something else called plasminogen, and when we turn that on, it becomes something called plasmin. Plasmin is going to dissolve that clot and break it up. That's the long and short of it. It's going to be, plasminogen is going to be turned on by something called tissue plasminogen activator, TPA. TPA, by the way, this is what we give to people who have strokes, as long as it's not a bleeding stroke, and as long as they get to the hospital in 90 minutes, because it breaks down, it's going to cause the clot to break down. The other thing, just in case some of the plasma gets a little further on, we actually have chemicals floating in the blood which will turn it off so that it doesn't cause anything in areas downstream from this. And then there's a PAI, plasminogen activator inhibitor, but we don't have to go this. Now this is the one I wanted to show you guys. I wish I could make this bigger, but so there's our injury. Red, we're getting red and white cells. Vascular spasms, we're trying to plug this guy. Platelet plug formation, we're making a plug on there because the platelets are getting sticky because they're sticking to the collagen there. And then at this point, to get the fibrin, we need coagulation. This is where we come from. Let's see if I can do this. There's two pathways, and these two different pathways come together. There's an intrinsic pathway, and there's an extrinsic pathway. So damaged vessel walls are going to cause, now this is factor 12. These are just chemicals, guys. Factor 12 is going to be turned on by chemicals released by the blood vessel walls. And that's what the little A's on there. So when it says 12 to 12A, that's just telling you that 12 is now active. It's been turned on. It's activated. Okay? 12A is going to cause 11 to be turned on. 11 is going to cause 9 to be turned on. 9 and 8, which has already been activated, together are going to take 10 and make 10 turn on. Now 10 is where these two pathways come together. So I'm going to go back up here and we'll do the extrinsic and then we'll follow this out. The extrinsic pathway, this is trauma to cells that are not actually part of the blood vessel wall. Factor 3 is going to turn factor 7 on. 7A and 3 are going to together turn on 10, just like in this pathway. This is a common one. 10 is going to turn 5 on, or 10 and 5 both are going to be turned on, and together they're going to take prothrombin, which is factor 2, turn it into thrombin, which is 2A. Thrombin is going to take fibrinogen, which is factor 1, and activate it into factor 1A. And remember, there's the calcium 13A. That's the one that's going to cause the cross-linking of it. It's really as simple as that. I know it seems like there's a big deal of difference, but everything is the same from here down. Only thing, this is the whole gist. We need to turn on factor 10. We need to take factor 10 and turn it on. Everything that happens over here is only to turn on 10, and so forth over here. Once we get 10 and 5 on, then we get our thrombin, and once we get our thrombin, we get our fibrin, and if we got our factor 13A, we can cross-link that guy. I think that is pretty much all we got on this, guys. You can look at these other guys. I mean, it's the same thing, guys. Tissue damage, 3, calcium, 7, changed on, 7 and 3 together, turn on 10. And then you get this guy from the intrinsic, the vessel walls. Platelet factor, calcium, factors 8 and 9. They're not even showing 11 on here, but that's one of the reasons I didn't want to do this. And then you've got the same thing here. But I really think that this one makes a lot more sense because you can see it in a straightforward, you start here and you wind up here kind of thing. And actually, the final common pathway really starts right there. Okay, so we talked about blood clotting. Now let's talk about what happens when it goes wrong. Okay. What if I get a clot in a blood vessel that's not broken? Well, that's wrong and it's abnormal, and we call that a thrombus. Just to let you know, another name for platelet, remember we talked about thrombopoietin? Another name for platelets is thrombocytes. You'll see that on the lab reports in the hospital. So these thrombocytes will make a thrombus. That's the clot. That's all thrombus is a blood clot. Now, if this thrombus doesn't stay steady, if it actually breaks and starts floating down the blood, then we call it an embolus. So what's an embolus? It's a thrombus that's moving. It's going someplace. These not necessarily a problem, but the problem is that these guys will eventually find a blood vessel that they are bigger than. And if they can't pass there, then they're going to act like a dam and there's not going to be any blood flow. Just so you know, that's where 85% of our strokes come from. And that's where our, well, not an embolus, but thrombus is where we get problems. It causes heart attacks. And that damming is called an occlusion. There's some more terminology for you. Other abnormalities, when you don't have enough platelets, that's called thrombocytopenia. Penia means poor. So thrombocytopenia means your platelet count is down. What's going to happen? You're going to have lots of little bleeding spots under your skin, like little teeny tiny bruises. They're going to be pinpoint dots. That's where you're getting bleeding from real small blood vessels like capillaries underneath your skin. We call those petechia. Now there's a lot of things. If you use all your platelets up at one time, or if you're just not making enough platelets, you'll see this petechia. Now petechia itself is not a disease. It's kind of like anemia. It's a sign that there is a disease going on, and you still have to try to find it, what it is and what's causing it. Hemophilia. Oops, I didn't know that thing moved. Hemophilia is when something goes wrong in our clotting cascade. So let's kind of break these into different categories. Okay, so hemophilia A, this is the classic kind. You don't have factor VIII. Factor VIII is right there. Without factor VIII on the intrinsic pathway, you cannot turn on 10. You're not going to make thrombin, guys. Hemophilia B, you lack number 9, which is right. No, I'm sorry, that's 11. There's 9. You lack number 9, and again, without 9 to turn on, it's if you're missing 9 or 8, either one, in the intrinsic, you're not going to be able to turn 10 on. Without 10, stuff's just not going to happen right, okay? Hemophilia C. Now, I should say this too. Most of these guys are due to genetic defects. The genetic defects is on the X chromosome. Now, women have 2 X chromosomes, but guys have an X and a Y. So if a woman has a defective X chromosome, she's got one good. She's got a spare. But if you have a defective X chromosome and you're a guy, you're out of luck because you don't have a spare. That's why a lot of these, now this woman here would be a carrier. She can give it to her children, or specifically her male children, but this guy is going to have the disease. That's one of those X-linked genetic diseases. That's just the way it is. And about 77%, a great majority of the cases are going to be the classical or factor VIII deficiency. Now there's also hemophilia C, which is not going to be on the X chromosome, and this one is going to be factor 11 right up here. 11, it's going to be hard to turn 9 on, but 9 can also be turned on by factor 7, which is way over here. So it's still possible to get it. It's going to be considerably milder. What kind of problems do these folks have? Well, they bleed into their joints. Those are extraordinarily painful. They used to treat this with transfusions, plasma, but mostly injections of clotting factors. This is expensive, so you take all these blood donations that you get and you screen through the blood and just remove those clotting factors. All these clotting factors in the inactive form are floating around in your blood waiting to be turned on. It's kind of inconvenient. However, people are able to stay alive, which is a lot more than they used to be able to do. But with hemophilia, even simple surgeries like dental or scraping your knee, or even bumping yourself, some of the hemophiliacs back in the last century really had problems. If they fell down and they ruptured an internal vessel, they had no way to stop the bleeding, and so it would bleed and cause that joint to swell up, and very painful, guys. Okay, blood transfusions. Sometimes you give whole blood. Generally, we don't give the whole blood. What they do is they filter through the blood. They actually put it on a centrifuge, and as they spin it, the blood cells, being heavier, come to the bottom. Remember that hematocrit diagram we had? And then the plasma will be up here because it's lighter. So it's kind of easy to separate these, but we give packed red cells. We generally will give IV fluids if they need actual fluid volume, but red cells are to deal with anemia, to keep our patients' blood or oxygen levels up. But this is preferentially. We do that instead of giving whole blood. Now, we're going to talk about this in the lab too, so if history is any indicator, and it always is, people have a lot of trouble with this, so it does not hurt to hear it more than once. On those red cells, there are molecules. These molecules, these glycoproteins, we can call them antigens. Okay, that's all there are. And if the antigens don't match up with the person's body that the blood is coming to, then the immune system will look at it as being a foreign invader and will attack it and destroy those blood cells and cause a lot of problems. So that's why we have to type and cross-match our blood before we give it to people, whether it's red cells or whole blood. Those blood cells, if they got the wrong one on it, the antibodies will attack it, attach to it, and oftentimes they will attach to several, and you'll actually get a lot of these guys chained together, and that's called agglutination. And that's big clumping. A lot of times they prefer to call these antigens agglutinogens. I just call them antigens, okay? Yeah, they cause agglutination if they're wrong, but they're still just antigens. Okay, here it is, guys. ABO blood group. There are only two antigens. There's an A antigen and a B antigen. If you've got the A antigen on your blood cells, you are type A blood. If you've got the B antigen, you're type B blood. If you got both of them at the same time, which happens, you are AB. If you don't have any antigens, then you're type O. O is in 0, okay? That seems as simple as I can make that. So that's the way. Now, this is the place where people get confused. If I've got type A blood, then I will have antibodies against the B antigen. I won't have antibodies against the A antigen because that's what I've got on my blood. And I can't have my immune system attacking my own blood. If you've got type B blood, you have antibodies against the type A. This is what confuses people. If you've got group B blood, then you have antibodies against A antigens. If you've got A, you've got them against B antigens. Well, what if you've got A and B? Well, guess what? You can't have any antibodies because if you did, it would attack your own cells. If you had anti-A or anti-B, these cells would be killed, and that's not a good idea. However, if you've got group O and you don't have any antigens, you're going to have anti-A and anti-B. That's as clear as I can explain it, but what you guys need to do is to spend a lot of time with this chart until you understand it. If I tell you that somebody had blood and that I put anti-B in there and it clumped it up, you're not going to say it's type B blood. Well, I mean, it is, well, excuse me. You're not going to say that anti-B goes with type B blood. That's just making it more confusing. Let me see if I can figure out how to do this. Let me ask you a question. So if I said, if I've got group A blood, what type of antibodies do I have? Most people will say A antibodies. See, that's what I'm trying to say. This is what confuses people. If you've got type A blood, you do not have anti-A, because if you did, it would destroy your blood. You have anti-B. So type A antigens on your blood cells goes with B antibodies. Type B blood, and you've got antibodies against A, and so forth. Okay, that's the ABO group. There's also such thing as RH. RH, these are actually, we talked about A and B antigens. There's also another one called the D antigen. D antigen is also the same thing as RH. We kind of use them interchangeably. So there's our O antigens. There's no antigens on there. There's A antigens, and I see the A's there. There's B antigens. I see those. I see A and B, and I got both of them on there. Now, the reason these guys have a negative is because they don't have any RH on there. Okay? But if I have O positive, what does that positive mean? It means I've got RH. I've got the D type. So A positive, I've got the A antigens plus I've got RH. So A positive is A antigens plus D antigens. A negative is A antigens and nothing. No D. Same thing with B and AB. It's really simple, guys. Spend time with this, guys, because I'm telling you right now, this is a known pothole because people confuse this in the lab and in the lecture, and you're going to be tested on it in both places. Here's abnormality. Hemolytic disease of the newborn, erythroblastosis fetalis. So this is what happens. Mom is Rh negative. Doesn't matter whether she's A, B, O. She's Rh negative. She marries a guy who has Rh positive blood. They make a baby. So there she is. Now that baby could be negative or positive, but in this case it's positive. So mom is Rh negative and the baby is Rh positive. Now she delivers that baby, and during delivery, blood from the mom and the baby's cord get mixed up together. So mom is exposed to blood that has the Rh antigen on it. Well, this baby is delivered. He's fine. Now what happens is, since mom's system has seen Rh positive, she develops antibodies against Rh. She didn't have them before. Now I said when you had A positive or A type blood, you automatically have B antibodies. It just happens. But Rh, you don't have antibodies against it unless you actually have it exposed to you. So she gets this Rh positive antibodies. The next time she has a baby, if it turns out to be Rh positive, those antibodies are going to cross the placenta and attack the baby and could possibly kill it, because the baby is going to become severely anemic because all the baby's red cells are being attacked by mom's antibodies. That's hemolytic disease of the newborn. So in order for this to happen, mom has to be negative and dad's positive. What if it's the other way around? What if mom is positive and dad is negative? Mom can't make antibodies against her own blood. She's not going to make anti-Rh antibodies. If the baby is Rh negative, then that means there's nothing there. So how are you going to make an antibody against something that doesn't exist? So it doesn't work that way. It has to be Rh negative female, Rh positive male. What if they're both Rh negative? It's not going to happen. Okay? The first baby gets a free ride because he's going to get delivered before mom is exposed. But it's the next few babies that are going to be the problem. So what are we going to do about this? What we do about that is, once we know that mom is Rh negative, once we have a good indication that dad is Rh positive, we're going to give mom something called RhoGAM, RHOGAM. And what it is basically is it's antibodies against Rh positive. Wait a minute, how's that going to help? Well, these antibodies are going to destroy that baby's Rh positive blood. I mean, we're talking about after delivery, guys, okay? Not before. But after delivery, those few Rh positive blood cells from the baby that get inside mom's are going to be destroyed by the RhoGAM. So mom's immune system never sees it, and she doesn't make any antibodies against it. The next baby will be safe, although we'll have to do the RhoGAM again. Well, guys, that's it for Chapter 18. I hope you got it. Let me know if you got any questions.